Severe congenital neutropenia (SCN) is an immunodeficiency disorder look at these pictures. Signs and symptoms. Look at this. Detail going on. Introduction. SCN is a rare hematological disorder characterized by an abnormally low level of neutrophils from birth. Neutrophils are essential white blood cells that defend the body against bacterial and fungal infections. The condition often manifests early in infancy with recurrent and severe infections requiring lifelong medical care. Definition: SCN is defined as a primary immunodeficiency disorder presenting with persistent neutropenia, absolute neutrophil count less than 500 per new L from birth, leading to recurrent life-threatening infections. Etymology: severe denotes the critical nature of neutropenia. Congenital indicates presence from birth. Neutropenia derived from Greek neutron, neutral referring to staining properties of the cells, plus penia, poverty or deficiency. Epidemiology: incidence 1 to 2 cases per 200,000 live birth worldwide. Both genders are equally affected. Familial clustering observed in autosomal recessive or dominant inheritance. Risk of progression to myelodysplastic syndrome (MDS) or acute myeloid leukemia (AML) in 10 to 20% of patients. Types: 1. Costman syndrome, classic autosomal recessive form. 2. Autosomal dominant SCN, mutation in ELANE gene. 3. X-linked SCN, rare. 4. syndromic SCN associated with metabolic or developmental abnormalities. Example, glycogen storage disease type LB, Skitchman Dynamont syndrome. Causes: 1. Genetic mutations, most common ELANE, HAX1, G6, PC3, GFI1. 2. Defective granulopolysis in bone marrow. 3. Inherited in autosomal dominant recessive or X-linked patterns. Risk factors: 1. Family history of congenital neutropenia. 2. Consanguinity in parents. 3. Specific gene mutations. Complications: 1. Recurrent bacterial fungal infections, skin, lungs, oral cavity. 2. Sepsis and septic shock. 3. Growth and developmental delays. 4. Risk of bone marrow failure. 5. Increased risk of MDS, AML. Pathophysiology. Step-by-step pathophysiology of SCN. 1. Genetic mutation occurs. Mutation in genes such as ELANE, HAX1, G6PC3, GFI1, WAS, JAGN1 disrupt normal neutrophil development. Inheritance may be autosomal dominant, autosomal recessive, or X-linked. 2. Defective granulopoiesis in bone marrow. Normally, hematopoietic stem cells differentiate into myeloid precursors, promyelocytes, myelocitis, metamyelocitis, mature neutrophils. In SCN, due to mutations, mutation arrest occurs at the promyelocyte or myelocyte stage. 3. Apoptosis of neutrophil precursors. Misfolded or unstable proteins from mutated genes triggered stress pathways in the endoplasmic reticulum, stress. This activates apoptosis of precursor cells instead of allowing maturation. 4. Reduced neutrophil output to peripheral blood because of bone marrow precursors die prematurely. Absolute neutrophil count ANC drop less than 500 νl. Other white blood cells, lymphocytes, monocytes may remain normal, but neutrophils are critically low. 5. Deficient innate immune defense. Neutrophils are the first responders to bacterial and fungal infections. With few or no neutrophils, the body cannot mount an effective immune response. 6. Recurrent severe infections. The child develops skin abscesses, pneumonia, otitis media, gingivitis, periodontitis, and sepsis early in life. Opportunistic bacteria, Staphylococcus, Pseudomonas, E. coli, and fungal cause infections. 7. Bone marrow stress and CSF response. The body increases natural granulocyte colony stimulating factor levels to stimulate neutrophil production. In most cases, exogenous CSF therapy helps overcome the block, but some mutations remain resistant. 8. Long-term consequences. Chronic bone marrow stress and colonal instability increases the risk of transformation to myelodysplastic syndrome or acute myeloid leukemia. In short, gene mutation to defective neutrophil mutation to apoptosis of precursors to severe neutropenia to impaired immunity and recurrent infections and long-term risk of leukemia. Signs and symptoms. 1. Recurrent fever. 2. Oral ulcer, gingivitis, periodontitis. 3. Pneumonia, otitis media, skin abscesses. 4. Poor wound healing. 5. Sepsis in severe cases. Diagnosis. 1. Blood test CBC with differential ANC less than 500 νl. 2. Bone marrow aspirations or biopsy. Mutation arrest at pro-myelocyte stage. 3. Genetic testing. Mutation analysis. 4. Flow cytometry or immune workup to rule out other immunodeficiencies. Nursing diagnosis. 1. Risk of infection related to decreased neutrophil count. 2. Impaired oral mucous membrane integrity related to recurrent ulcers. 3. Imbalanced nutrition less than body requirements related to recurrent infections. 4. Anxiety related to chronic illness and hospitalization. 5. Risk for delayed growth and development. Medical management. 1. Administration of recombinant human granulocyte colony stimulating factor G CSF, example filgrastim. 2. Broad spectrum antibiotics and antifungals for infections. 3. Hematopoietic stem cell transplantation HSCT in refractory cases. 4. Regular monitoring for progression to MDS AML. Nursing management. 1. Strict infection control measures, hand hygiene, protective isolation. 2. Monitoring vital signs and early signs of infections. 3. Oral care to prevent gingivitis and ulcers. 4. Nutritional support and growth monitoring. 5. Patients and family education about home care and emergency signs. Treatment options. 1. G CSF therapy first line. 2. Antibiotics, antifungals, infection control. 3. HSCT curative option in severe or refractory cases. 4. Gene therapy emerging experimental approach. Psychosocial medicine. 1. Counseling to address anxiety, fear, and emotional burden. 2. Support groups for families coping with chronic illness. 3. Educational support for children with frequent absences from school. 4. Family therapy to strengthen coping strategies. 5. Financial and social services support for long-term treatment costs. Prevention. 1. No primary prevention, genetic condition. 2. Genetic counseling for at-risk families. 3. Prenatal and pre-implantation genetic diagnosis PGD for carriers. 4. Early screening in siblings if family history is positive. In conclusion, severe congenital neutropenia is a rare but life-threatening disorder presenting early in life with recurrent infection due to defective neutrophil production. Advances in genetic testing, G-CSF therapy and hematopoietic stem cell transplantation have greatly improved survival. Early diagnosis, vigilant infection control, and psychosocial support are crucial for improving quality of life and long-term outcomes. Thank you. Have a nice day.